Good morning. Happy Wednesday. We'll go ahead and get started with rounds. I am Dr. Kelsey Brown, one of the pathologists here at Coplow, and I am going to start with the first two cases. So first one, I do not have a gross photo of, but we have these lovely images provided by the clinician. So this case features both eyes. We got both globes. Let me see. And these are the globes from a 11-year-old female spayed Maltese mix. And the history provided by the clinician was that both eyes had negative menace and dazzle reflex. They described conjunctival hyperemia, diffuse 360-degree deep stromal neovascularization, and they suspected fibrinohemorrhagic debris within the anterior chamber, but very hard to visualize any normal ocular structures as we really can't hear these images either. They also mentioned that there was poor quality tear film and fluorescein stippling in both eyes. No glaucoma, and for general medical conditions, they said this dog did have diabetes mellitus and possibly Cushing's disease as well. And we don't have a gross image, as I mentioned, but I can paint you a bit of a word picture with our gross notes here. So we said for both eyes, the cornea was opaque and thick. There was a hypermature cataract and the vitreous was liquefied, so it was degenerate. And then we also described a tan carpet lining the uveal surface. All right. We'll switch over. We'll open up cell phones. Please hold.
I'll see. I forgot.
Oh,
I'm
all
looking
good.
at something else.
I couldn't hear earlier. I could have done it too. Nice intermission. All right, we're back. Okay. This is one that's probably worth doing a subgross. And the eye is small enough that I think we can do it. Maybe. Okay. All right, so here's our subgross image. We have our hemisection. On this slide, we also have a little, what we call a gonio slice. It's just to help us see more views of the angle, as well as a little bit of third eyelid, but we'll just focus on this hemisection. So cornea is up top. Our posterior segment is going to be at the bottom here. We can see a little bit of the optic nerve right there. And from this view, kind of hard to make out the fine details, but we can see that the cornea is indeed pretty thick. It's a little busier. There's more blue, which usually corresponds to increased cellularity. Like we're really shaking, sorry. We can make out this pigmented tissue, which is going to be the uvea. So a little bit of iris and maybe ciliary body. They're kind of distorted and blending together here. A little hard to make out which is which. And then we have in what I assume is our anterior chamber, just also increased cellularity. So just more blue. And this is probably that tan carpet we mentioned grossly. As we go back, even from this view, we can see that the lens has a cataract, or there's kind of this little area here, this kind of little suture, where the lens fibers look a little different. And then our retina is detached, is kind of plastered against the posterior lens capsule. All right. Okay, so the globe has been flipped 90 degrees. So our cornea is now on the right. As we move left, posterior segment, here's a little bit of lens. So starting with our cornea, it's kind of some somewhat non-specific changes. One closer. There's a little bit of hyperplasia of the corneal epithelium. This is a few too many cells thick. There's also some pigment in the corneal epithelium, which we should not see. So we do have a pigmentary keratopathy or keratitis. As we move in, back out one perhaps. There is indeed increased cellularity within the corneal stroma. So we have some lymphocytes and plasma cells infiltrating the stroma. There are quite a few vessels in here as well. So vascularization, which they describe clinically. And as we move around, there are some areas where there's also more of these kind of spindle cells. The stroma kind of has this looser quality to it. So likely there's also some fibroplasia on top of that. So just a lot of chronic corneal changes. Yeah, here's a little bit more of that fibroplasia kind of on the background. As we move posteriorly, still within the cornea, we can make out Descemet's membrane right here. And as we follow it, it does become discontinuous. We're at about the axial cornea right here. And it's a pretty broad discontinuity. Here we pick up a fragment of it. There's another little break, and then there's more desmase membrane as we head to the periphery of the cornea. And in this region, there's these inflammatory cells that are kind of carpeting the posterior aspect of the cornea and kind of lightly infiltrating what we have left of the stroma here. So again, kind of more lymphocytes and plasma cells. As we get into the anterior chamber, we kind of transition into more macrophages. I'll go one closer. Up a little bit. There we go. Macrophages, and these little squiggly guys are neutrophils. As we move over, over to our uveal tract. So this is iris, or what was once iris. It's pretty distorted. It's kind of plastered against the posterior cornea. So we have this broad anterior synechia. And then we move over here. This is going to be more of our ciliary body. And going in closer, there is a lymphoplasmacytic uveitis, so lymphocytes and plasma cells within the uveal stroma. And as we move back, just to kind of give a full tour of the uveal tract, there's also similarly lymphocytes and plasma cells within the choroid. So we have a lymphoplasmacytic panuveitis. All right, now actually looking at these carpeting cells a little bit more. On the uveal surface, we have this kind of really thick membrane. It's infiltrated by lots of cells. And on top of that membrane, we have these layers of macrophages. I feel like maybe just on the screen, it's a little bit hard to see the colors. I don't know if it's very balanced. So we have all of these epithelial macrophages carpeting the uveal surface. And as we move out a little bit more, there's quite a few neutrophils. There's kind of layers of fibrin on top of that carpet of macrophages. I'll kind of scroll around a little bit more. So here's the other iris leaflet, also quite distorted. And similarly, we just have this thick carpet of cells on top. So mostly macrophages, it's kind of carpet here. And as we scroll around, just kind of more fibrin, some neutrophils. And in some areas, we have all of these bright pink globules, which is liquefied lens protein. So kind of this whole picture here, this panuveitis, we have this carpet of epithelial macrophages and neutrophils, and then liquefied lens protein within this inflammatory exudate. This is all very, very suggestive of asynchronous uveitis, which is believed to be a very robust reaction to lens protein, or a hypersensitivity reaction to lens protein. So in this case, we do have the lens protein in the chambers to kind of help corroborate that. And on top of that, we also have lens capsule rupture. So we have a very good reason for exposure to lens protein. So we don't really have any lens capsule to speak of here. It's really just the lens fibers. Sometimes artifactually, we can see the lens capsule kind of get shorn away just during sectioning. However, in this case, we also have inflammatory cells kind of lining the lens fibers and munching them up. So this is all very definitively diagnostic for a lens capsule rupture. With asynchronous uveitis, we don't necessarily need to have lens capsule rupture to see this inflammatory reaction. We can just have a cataract, so the liquefied lens proteins can traverse the intact capsule and cause a similar reaction. Just in this case, we do have lens capsule rupture. And just to kind of wrap up the full picture here, here is our retina, which is detached. It's also quite inflamed. So there are lymphocytes and plasma cells within the retina as well. And there's some areas as we kind of walk along the retina where it becomes necrotic. We kind of just lose the architecture of the retina. And looking back here at our choroid, we also have a similar carpet of those epithelial macrophages, which is again part of just the entity of asynchronous uveitis. And then our optic nerve is kind of distorted by this detached retina. I can quickly, this is kind of a lengthier case because we have two eyes. I'm going to quickly show the other eye. So that was the right eye. This is going to be a left eye. We again have cornea on the right, posterior segment on the left. Ignore this giant scratch, this artifact. And this one similarly has features of asynchronous uveitis. So this is going to be our iris and our ciliary body. There's a panuveitis. We again have those epithelial macrophages and neutrophils carpeting the uveal surface. And on top of that, we also have a lens capsule rupture and cataract formation. So we can see all these liquefied lens proteins. We have these little more ganglion globules. We have maybe more normal lens fibers as we go a little bit deeper. And this one, interestingly, also has that kind of break in desmase membrane that we showed in the other eye. This one's a little bit more severe, in fact. So this is going to be cornea. We have this large cavitation that's filled with inflammatory cells. And then as we get a little bit deeper, here's Descemet's membrane. So this cavitation's within the corneal stroma. And somewhere here we pick up Descemet's membrane again. And in that corneal stroma, it's just a ton of epithelial macrophages, neutrophils. In some areas, we have these little globules of lens protein that have made their way into the stromal cavitation, which is, I don't know, kind of bizarre. Sometimes with asynchronous uveitis, we can see kind of inflammation head into more of like the limbal stroma right here. There's just kind of this progressive weakening right here, and inflammation will extend into that. I haven't had many cases where we'll see like these breaks in Descemet's and like stromal inflammation.
Interestingly, I wrote a case yesterday that was a bilateral enuke.
Yeah.
Both of them had Descemet's membrane rupture and like a deep corneal stromal like abscess. And
Weird.
like, what is going on? It's so weird.
That's so bizarre. Yeah.
Yeah.
I think in this one, we maybe postulated like maybe there is concurrent blunt trauma. The fact that it's bilateral is a little bit weird, unless the dog just somehow, I don't know, got poked in both eyes.
Yeah.
Yeah, but there's see ruptures of Descemet's membrane with deep stromal keratitis and worse is they have those big deep stromal abscesses. So it could be, I think, both, either trauma.
Yeah.
Although bilateral identical trauma would be a little.
Yeah.
And also
bizarre.
both globes I had, I couldn't find lens capsule anywhere.
Oh, really?
Yeah.
Oh, interesting.
It was bizarre.
That is strange.
It was really weird.
Huh. Interesting.
Yeah.
All right, let me go to diagnoses. This one. So yeah, kind of bottom line for both of these, this is asynchronous uveitis in both eyes. So as I mentioned, this is kind of a hypersensitivity reaction or severe lens-induced reaction to lens protein. This was formerly known as asymmetric uveitis. However, we've been kind of slowly transitioning to changing this to asynchronous uveitis, which kind of better depicts the clinical picture. So typically, the eyes will have symmetric lesions. However, they occur at different time points. So one eye will go and then the other eye will go. So it's an asynchronous presentation. But then you'll look at this case and say, wait, this eye seemed to present at the same time with these bilaterally symmetric lesions. What's up with that? Well, we can see cases where there is both eyes will kind of go at the same time, which we jokingly call synchronous asynchronous uveitis, just to make it confusing. And we see that most commonly in diabetic dogs, which this dog is diabetic. So this kind of helps fit that clinical picture. On top of that, we do have the lens capsule rupture, which provides a really good reason for exposure to lens protein. It's possible lens capsule rupture could have been traumatic. However, this is a diabetic dog, so it'd be reasonable to wonder if there was an intumescent cataract that spontaneously ruptured. And then, yeah, on top of that, we also have this raging keratitis, possibly due to extension of inflammation into the corneal stroma. Maybe there was trauma on top of things. Hard to say in this case. I think that's most of my spiel. I don't know if anyone has anything to add, any questions. Otherwise, I'll move on to my next one. This one I actually have a gross photo for. All right. So this is the glow from a 1-year-old, 1 day, male castrated German Shepherd mix. And it looks like for our history, we may have gotten the history from the recheck exams. I don't quite know what was initially seen. But it sounds like the eye was initially diagnosed with uveitis. On recheck, that uveitis had improved, but now there was uncontrolled glaucoma, and they felt that this eye had no vision. Those are kind of the main points with that. So the other eye was normal. So in the gross image, hard to tell in this image, but grossly we said this globe did look ophthalmic. We described that the anterior chamber was collapsed. So all of this pigmented tissue here along the posterior aspect of the cornea, maybe adhered to the anterior lens capsule, is uveal tissue. So we have this broad anterior sneaky and just no anterior chamber to speak of. Other things we mentioned, kind of the lens was a little bit funny in shape. So there was a little bit of a protruding of the anterior lens. And then in the posterior aspect of the globe, in the vitreous, there were kind of these little wisps of hemorrhage, a little bit of it. And we said the vitreous was a titch cloudy. Actually, clean this one off. Right. Gross. This one's a little bit bigger. Also, this one's a little bit distorted, so hard to hold correctly. Okay, so scope's a little bit bigger, hard to fit all on the screen, but cornea's up top. We have our lens, posterior segment will be back here. So we move back. So from here, the cornea looks kind of thinned. We have kind of this weird peeled away area of iris, but the rest of the iris, we can see this pigmented layer. This is all iris that's adhered to the posterior cornea. So we indeed have broad anterior synechia. The cornea looks maybe a little bit busier too, but we can go closer to show that. Move back. Here's our lens. Histologically, the lens wasn't particularly exciting. We had described a slightly funny shape to it grossly, but there wasn't really evidence of a cataract or much else, so probably won't hurt too much on the lens. And then posterior segment looks pretty unremarkable from low power view. There are some suspicious dots. We'll get to those later. So same thing here. Globe's been flipped 90 degrees. Cornea will be on the right or right-ish, kind of at a weird angle on the slide. We can ignore this little bonus segment of retina. And we will start with our corneal lesions.
The outer retina?
Yeah, the extraocular retina. All right. So starting at kind of low-ish power, corneal epithelium is intact all the way throughout here. There's kind of this funny tinctorial change to the corneal stroma. It almost looks like Neapolitan ice cream, I think. There's like 3 different layers here. Maybe in the middle, we have some normal-ish stroma. Usually it just has this pale eosinophilic hue to it. In the other areas, it becomes much more dense and busy. There's increased cellularity. So in these areas, I'd say even at low power, it looks like there is some stromal fibroplasia occurring, as well as some sort of cellular infiltrate. There's also robust vascularization. So all of these guys are little vessels. I think this one also had, this giant stromal vessel that maybe a skilled practitioner could catheterize if they wanted to. It's huge. I'll go even one closer. And actually put the condensed front. As we get a little bit closer, there is kind of a smattering of inflammatory cells. These are little lymphocytes and plasma cells. Not crazy inflamed, but they're there. So there's a bit of a keratitis as well. So all just chronic corneal changes. And as we move back, the next layer we should encounter would be Descemet's membrane. However, he is not in the building, at least in this particular view. And instead, this kind of layer of fibroplasia just blends seamlessly with the adherent iris. I think there are areas in this particular slide where maybe we do pick up Descemet's somewhere. It would have been a great idea for me to get a PAS to better show this. But here I am. There we go. So a little bit of Descemet's right here, but we have pretty broad breaks in it. And I imagine this was an area where maybe the iris was also adhered and maybe just got peeled away during sectioning. Okay. I mentioned lens itself was pretty unremarkable, at least histologically. As we move back, there's like maybe a titch of inflammation in the uveal tract. So some lymphocytes and plasma cells in the ciliary body. It's pretty minimal. That's there. And then moving all the way back to our posterior segment, remembering that this dog did have glaucoma clinically, we weren't able to corroborate that histologically. So there really is not atrophy or cupping of the optic nerve head. There's some gliosis in the optic nerve. However, that's not terribly specific. And then the other thing we'd want to look for to confirm glaucoma histologically would be retinal atrophy. And typically that manifests first with loss of our ganglion cell layer. In this case, we have a good number of ganglion cells still.
Yeah, if you're interested in learning what a relative and normal retina in a dog looks like.
This is a nice one. Yeah. So in this case, we weren't able to confirm histologically that there was glaucoma. I would absolutely believe the clinician when they diagnosed it. We have great reasons for it. We have a collapsed anterior chamber. I really don't think this is a functional drainage angle, whatever is left here. However, we're not able to confirm it microscopically. I feel like in a lot of these younger patients that have glaucoma, we don't always see like severe glaucomatous injury. Possibly they can just compensate for that high IOP better. Something about, the elasticity of the fibrous tunic, something like that. But this dog, is not showing that glaucomatous change that we'd like to see. So these lesions, the anterior segment, this loss of Descemet's membrane, the broad anterior synechia, we have this stromal fibroplasia. We had proposed that this could be fall under the entity of anterior chamber collapse syndrome or early life trauma, which, as kind of the name says, typically there's a traumatic event that happens early in the life of the patient, and it causes these corneal lesions. We'll see breaks in Descemet's membrane, and we'll just see these broad anterior synechia, causing loss of the anterior chamber and then a secondary glaucoma. This is a young patient. So this dog was 1 year old. Depending on the history, this could also be consistent with some sort of congenital malformation. So like Peter's anomaly, where there's just failure or separation of the iris from the cornea. In this case, just due to the degree of stromal fibroplasia, kind of these corneal changes, we thought trauma is perhaps more likely. In this case, the other eye is normal. So this is probably an academic discussion, but those are kind of the main differentials. And then on top of that, we also have those bonus dots. So kind of at the peripheral retina, we have this area where the retina is separated from the choroid. There's kind of just this little blob of cells right here. Let's make it closer. There's a little granuloma. Look how cute. So these are all macrophages that are just, oh my gosh, that are lifting up the retina here. We can still see some of the melanin granules from the retinal pigmented epithelial layer. So this granuloma is disrupting that RPE layer. And embedded within that granuloma is a single fungal yeast. Here he is. We did not see this grossly, so this is a very fortuitous discovery. So yeah, we have this cute little round fungal yeast. There's kind of just this flocculent material, and there's this kind of somewhat refractile wall of the yeast. So in this case, a couple differentials we could consider for this guy. This could be blastomyces dermatitis. The other thing we'd want to consider is could this be an early form of coccidioides? This dog is from Arizona, so I think it's very, very possible it could be coccidioides. Unfortunately, we just have one yeast to look at. We don't have any other definitive features to help us differentiate between the two. So if we saw broad-braced budding, we could say, yeah, this is probably blasto. If we saw the more mature endosporulating form of coccidioides, then we could lean towards that differential. In this case, we just have this one kind of immature looking yeast. So we recommended that they look for systemic fungal infection and also consider more kind of definitive clinical testing to see if they could differentiate between the two. That said, if this dog has never left Arizona, then I guess my money would be on coccidioides in this case.
No clinical history of any systemic disease at all?
Nope.
Yeah.
So I don't know.
So there's a possibility that, well, there's this idea where dogs will have systemic fungal disease and they will have a later ocular disease or ocular disease in the later stages, and they get treated for the systemic disease. But since the eye is such a closed environment, the systemic treatment is not able to reach treatment levels inside the eye. So there's a persistence of organisms inside the eye. And if that, the idea of those cases is that enucleation might be even a form of treatment, because that could, that ocular infection could work as a nidus for a reinfection systemically later. So it's interesting. And I think another interesting thing about it, it looks, well, not now because it's formalin fixed and on the slide, but it looks like a viable organism in a way, right? It's not degenerated. You can see DNA material. Really hard to tell, assess viability on the slide, but it doesn't look like just a leftover of a degenerated organism, right? So there are two possibilities that denucleation actually fixed the problem. Now we don't have anymore, but we cannot rule out that this became already systemic, or if there is an already established current systemic infection that was not diagnosed. Very cool.
Yeah.
I don't think I've ever seen this, like such a small,
right? This kind of freaks me out. I'm like, oh,
infectious granuloma like that with like typical or still viable looking.
And we just like so luckily cut it in too.
Right, I know. Right.
Papers to look for more, like you obviously only have one organism, like to look for more to have a better idea as to what it is, or I guess it doesn't like change anything in this particular case, but is that something you thought about or did?
I mean, it'd be reasonable to do. In this case, like we grossly didn't even see like granulomas anywhere. So I don't know if deeper is like if we would just lose this focus and then we wouldn't find anything. I don't know. I guess in this case we just opted not to, just to not delay the case further. But
In some
That's a good point.
cases, where we have like really obvious like pyogranulomatous or suppurative endophthalmitis, and you're like and especially if it's from an endemic region of one of the various yeast organisms, sometimes we'll go deeper just to see more tissue to look for yeast. For example, coccidioides in dogs, we see very few organisms often. So sometimes it's better to just do multiple deeper sections than do a fungal stain on a single, the one that you already looked at. Because you have a better chance of seeing organisms. Histoplasma is one of the is a bit different from blaster or coccidioides because it's so tiny. So we will often do a fungal stain for if we suspect histoplasma. But yeah, so sometimes we will go deeper. Maybe not something like this. And with this, it's like we may not ever be able to tell them whether it's more consistent with blaster or coccidioides. So it's better for them to just pursue it clinically and treat if they find signs of systemic infection.
Another, diagnostically speaking, also, it's a yes or no kind of diagnosis, right? The correct amount of organisms in the eye should have a 0, so you have 1 that's already abnormal. So there's a mycotic focal granulomatous mycotic granuloma in the choroid here. It will be deepers would help. We're able to find more organisms and get a better view of the organism itself. But as Guilherme said, it's so localized that, and Kelsey mentioned that we're probably going to miss it if we go deeper. So there, UFPR, Universidade Federal do Paraná, I think, asked here, were any special stains done? Yeah, go ahead.
So we didn't do any specials for this case. So for fungal organisms, we could pursue like a PAS or GMS. We mostly do that just to look for the organism and confirm that it's there. In this case, just with the routine stain alone, I'm very confident that that is a fungal yeast. So I don't think specials would tell us much else in this particular case.
And Allison was asking, are they doing any antigen test?
Unclear. We've had no follow-up.
Yeah, no follow-up. That'll be the first thing I think they should try to do.
Yeah.
Very cool case.
Yeah, it's gonna be fun. A little twofer. Okay. And with that, I will hand the reins over to Dr. Chow.
All right. So my first case is the globe from a dog. This is a 3-year-old dog, a German Shepherd mixed dog, neutered male, from Minnesota. And this is a nice follow-up on Kelsey's case in a way. So the history we got, most importantly, I'll just start with this. The dog has systemic blastomycosis, and they had started treatment with itraconazole about 20 days prior to enucleation. So the history we got for this eye was mild ophthalmos, conjunctival hyperemia, scleral injection, mild diffuse corneal edema, 2+ aqueous flare, severe dyschorrhea, which is a misshaped pupil, with multifocal diffuse posterior synechia and fibrin over the iris and the anterior lens capsule, rubiosis iridis, which corresponds to a pre-iridal fibrovascular membrane, and they said unable to evaluate the lens and the posterior structures. So they already know this dog has blasto, so do we. And this is a really lovely case to present right now because one of our audience members, one of the professional DVM students, presented about this at ACVP 2 years ago? 2 years ago, yeah. This is a case, I'm just going to tell you all the good stuff right now. This is a case of what we call spent blastomycosis, or spent fungal infection. So as they describe, oh, here, let's do this low power thing. So here's the cornea off to the right. Here's the iris and ciliary body. We've got this membrane reaching across the pupil and the anterior lens capsule. Here's more iris. There's a bunch of hemorrhage in the posterior chamber and the vitreous and the subretinal space as we move this way. The retina is detached. And then there's some extracellular stuff going on in the choroid. The retina is a little bit thickened and kind of a little bit busy as well. Our extra slice over here, there's some mysterious blue dots, but there's more of that like extracellular stuff going on. And so let's just go ahead and go deeper, go higher, Meg, rather. Okay. So, as they described, there is posterior synechia, which is when the iris is adhered to the lens capsule. So that's the posterior synechia right there. We obviously have a bunch of hemorrhage. This is, I think, the posterior chamber. It's a little hard to tell. I think, yeah, this is iris right here. So I guess this is ciliary body that's stuck to the lens capsule there. And here the iris is more adhered. And here's that pupillary membrane that they described, kind of fibrin and stuff stuck to the anterior lens capsule. And it's also a very poorly pigmented iris. So this is actually a blue eye. And then as we move back, here's the detached retina. And here's a bunch of junk under the retina. And then there's some cellular infiltrate up against and within the choroid. The choroid itself is very poorly pigmented, which goes along with this being a blue eye. And then we get back here to the retina gets quite thick. Let's take a look at what's going on there. So here is actually the span of the retina from here to here, kind of, and everything here is this jumble of cells that sort of adhered to the underside or the outer aspect of the retina. Here we have some hemorrhage, and then along with that hemorrhage, we have some foamy cells that have brown to yellow pigment in them. Those are macrophages that have red blood cell breakdown products. So the yellowish stuff is hematoidin. The more brownish stuff is hemosiderin. It's just the pathway of breaking down the heme in red blood cells. And then what we have here are a bunch of spindle cells and some bright pink fibrillar stuff. That's collagen. So we've got kind of a more chronic fibrotic response going on here. And then what we have here are also a bunch of macrophages, just as Kelsey described in both of her cases. So these are some macrophages. We also probably have some lymphocytes, and there's some plasma cells around. There are probably some neutrophils around as well. So I already told you the history. They know this dog has blasto. It's been treated. So at this point is really more of a hunt to try to confirm the finding of blasto in the eye. And let's go to this dot here. So somewhere in here, there is an organism. Oh, so in this spot, wait, hang on, let's see here. And I put this slide on backwards from the way I normally look at it, which is confusing to me. Well, so actually what we do have here, I'll put it right in the center. So unlike the organism that Kelsey showed right here, this is an empty yeast organism. So it is lacking the nuclear material. It's lacking pretty much all of its cellular machinery. So this is a here we go. This is a non-viable organism. These guys up here are a little bit more debatable. Mm-hmm. So these guys have some kind of nuclear stuff in their interior. So probably the one that's empty is a non-viable organism. And then I have another dot over here because I found one, I think, that was looking more viable. So this dog has only been treated for 20 days. And so here's another one here. Often they are a little bit out of this plane of focus with the rest of the cells. I'm not sure why that is. Anyway, so this dog probably still had, at the time of enucleation, some viable yeast in its eye. And with the degree of fibrovascular membrane formation and glaucoma, I think they said. I may not have said that out loud. They said ophthalmos, so yeah, it was glaucomatous. This eye was probably painful, and those two things, so having a blind, painful eye and one that might have yeast organisms in it, are two good reasons to enucleate an eye. So the other features of what we call spent fungal infection, I'll just cover right now. So those features are chronic intraocular hemorrhage, which we have, and we know that's chronic because we have all those macrophages with red blood cell breakdown products, the hematoidin and the hemosiderin, and also fibrovascular membrane formation, particularly epichoroidal. So here's our choroid, here's our sclera, here's the choroid, and that membrane that was under the retina also is continuous with membrane that's on the exposed choroid there. So all of those features, and then the finding of granulomatous, pyogranulomatous inflammation that we see with viable yeast infections, but often it lingers for quite a while after an eye has become inflamed with yeast, and often then, not often, but sometimes we can still find the yeast organisms. It probably depends on the length of time between when the dog became infected and the eye was enucleated, and also whether or not the eye was actually treated with antifungal, or the dog was treated with antifungals. Will all of the histologic features will depend on all of those things. So that was a slightly jumbled presentation of a spent fungal infection in a dog. So, any questions?
Yeah, it's great to see the difference between the exactly what we're talking about.
Yeah.
When we say dead organisms, it might be confusing, right? How can you define that histologic? But it's exactly what he was showing.
Yeah.
Glad it was one after the other.
Yeah. I feel like mine was actually more florid than yours was. I mean, it
Yeah,
was
yeah.
for sure.
Oh, yeah.
But anyway, two sort of unusual presentations of blasto, because most of them tend to be like the eyes full of pus, and we find the organisms everywhere. Okay, cool. So let's go back to the PowerPoint. Yes. So there we go. It was a little bit, sorry, the sclera was a little bit wrinkled. So early thesis bulbi, there's a pyogranulomatous cyclitis and choroiditis with rare intralesional yeast. And this dog was from Minnesota, which is unfortunately a good place to pick up yeast blasto. And so basically this was a spent fungal infection, or on the way to being spent. Let's put it that way. All right. So next case, this is a cat. It is a 12-year-old cat. Neutered male, domestic short hair. I don't have a gross photo of this one. Sorry, sad trombone. But the history was exam found a large, thick, rough, elevated, whitish corneal plaque with neovascularization ventronasally. Also, a smallish red mass was found on the posterior aspect of the third eyelid, deep within the fornix, which I feel like we never actually identified. They had previously biopsied something the RDVM had, and then the cat was seen by an ophthalmologist, which is, I think, the person who enucleated it. There was no response to erythromycin vidirabine. I don't know what that is. Is that an antiviral? I don't know. Topical and oral steroids, doxycycline and silvadine. So owners elected no further procedures except enucleation and histopathology. The biopsy report did report eosinophilic inflammation, so they thought maybe this was like an eosinophilic keratitis or something like that. But there was quite a prominent plaque. The gross notes say a white ventromedial limbal / corneal mass, and everything else pretty much about the eye was normal. So this is sort of a short but sweet case. So. Oops. All right, let's see here. Oops, doing this. Okay, we're actually going to focus on the extra slice of tissue, which is this here. So here's the whole globe. There's the iris right there in front of the hand, but we're going to actually focus on this lesion right here. So this is our extra slice, what we like to call the gonio slice. So we have cornea here, here's the iris and ciliary body, and as we move back, we get into the choroid and the retina, which we're basically going to ignore because all of the excitement is happening right here. Actually, so that it's right side up. Okay, so here we have relatively normal looking corneal stroma, and then we have the corneal epithelium, which is very thickened, and it's irregular, and there's a bunch of junk stuck to it. So let's dive right in there. So from this low power, the corneal epithelium is quite thickened. It's irregular. It's got these little like sort of papillomatous kind of frondy things. And then we have this really thick layer of brightly eosinophilic lamellated material, which is keratin. And then we have a bunch of junk. All that purple stuff is probably degenerate inflammatory cells. There might be a little bit of hemorrhage mixed in there too. And oftentimes we'll find either hair or like foreign material, which is probably like carpet fiber or something like that, stuck in like gross crusts like this. But anyway, so this right here is like absolutely classic for a papillomavirus induced papilloma or papillomatous lesion. So this is a cat. We often see papillomavirus lesions in dogs around the mouth, and sometimes they will also affect the conjunctiva or the skin of the face because they often get it from biting each other, even in play. But this is a cat, which is makes it much more unusual. I can't remember if there are any feline papillomaviruses. Are there? There probably are, but they're pretty rare. Cats have also been can also get bovine papillomaviruses, I think.
Yeah, it causes sarcoid.
Yeah, it causes sarcoid in cats and also boinoid. Is that
Feline papillomavirus 2 causes boinoid
okay.
and like a couple of other
All right.
various epithelial dysplasias, malignancies.
Okay, cool. So what we have here, here's the corneal stroma, which has inflammatory cells in it, and it is vascularized, so it's a little bit inflamed, which is very common whenever you're looking at a papillomavirus-induced lesion. There's often inflammation associated with them, and that's why eventually, hopefully, most immune systems can make them go away, and then they will not recur as the immune system gets sensitized and kind of deals with the infection. We have the basal layer here of the corneal epithelium, and then we have what ends up being a stratum spinosum, which should never occur in the corneal epithelium. And then as we go a little bit more superficially, we start to pick up cells that have dark purple granules. So those are keratohyalin granules. This is something that should occur in the epidermis, but it should never occur on the corneal epithelium, in the corneal epithelium. And the papillomavirus-induced lesions are classic for making the stratum granulosum layer more prominent. So this is more prominent than it ever should be on a corneal surface. And then what I also found as I looked around, I felt that there was just a little bit too much cellular atypia, jumbling, dyskeratosis. So whenever you have bright pink cells that are sort of in the middle of the epithelium, that's because they're keratinizing too early. So this is what we called dyskeratosis. And so I ended up calling this a squamous carcinoma in situ, which means that it doesn't invade past the basement membrane. And that means that as long as you remove it completely, there's no risk of metastasis from it. So papillomaviruses have been documented in humans and in animals to lead to squamous neoplasia. And so I think this is an example of that. And we always try to find inclusion bodies. I often give up very soon because the other features that I've already pointed out are pretty common, or I mean, pretty prominent. So I'm always already confident this is a papillomavirus-induced lesion. Here's a cell whose nucleus has kind of a pinkish center to it. I think this could possibly be a viral inclusion body in the nucleus. And that is where they end up with papillomaviruses, intranuclear inclusion bodies. Anyway, so that's just a really short but sweet case. I thought it was pretty cool. And one of the pathology residents here at the vet school and I are also working on a short case series of canine corneal plaques that are not necessarily neoplastic, like actual squamous neoplasia, but that have features very similar to this, one of which we were able to confirm actually had papillomavirus DNA in it via PCR. So hopefully we'll get that submitted eventually here. I'm ruining her thunder actually because it's going to be presented at ACBP too this year. Anyway, so that's about it. Let's go ahead and look at my very brief diagnosis. So corneal and third eyelid, it did kind of reach around. Bulbar conjunctival squamous cell carcinoma in situ with features suggestive of papillomavirus-induced neoplasm. So with clean margins, so good news for this kitty cat. And that is it. And now it's Megan's turn. I left a few minutes for Megan.
Hey, Megan. I have a complex case and like a moderately complex case, so we'll probably mostly do the complex case. All right. So this is a 7-year-old spayed female Australian cattle dog mix. We have both eyes from this pet. We have a hypermature cataract with lens-induced uveitis in the left eye and ocular hypotension, which has been persistent. A mature cataract in the other eye, the right eye, which progressed to hypermature cataract as time went on. Bilateral retinal detachment with vision loss. And that's the main thing. So basically uveitis, retinal detachment, and cataracts in both eyes, in summary. Also a generalized lymphadenopathy. And some skin masses. And they did an FNA of the left popliteal. The skin masses, they did some cytology, and actually those weren't necessarily something that was kind of conclusive. But we have additional things to discuss, I think, after we've revealed what the diagnosis is. Let me see if I've managed to also get us access to some additional photos before we get into the gross of the eyes. Here we go. Okay. Oh, come on. Yes. All right. Didn't manage to get these into the PowerPoint in time. However, we have them available. So this is our little baby's face, a little bit of kind of crusting, maybe some like excoriations or ulcerations potentially.
Post-nucleation.
I think this is post-nucleation. It very much looks like it. And then we have some ulcerative lesions. So here's one on the abdomen that's relatively new. Let's see. The one on the paw pad. And both pinna are kind of a little crusty like this. And the pinna has actually been going on for at least 2 years. So chronic skin things on the pinna. All right. So we have some more generalized signs that are a little concerning as well, but we'll keep that in mind as we evaluate the eyes. So here's both eyes, and you can see that they look relatively similar on the hemisected view. So both eyes do indeed have very advanced cataracts, as was noted clinically. We do have some cloudy corneas. Both eyes are relatively small, and there's some degree of wrinkling of the collagenous tunic. So essentially both are kind of progressing towards thesis at this point, thesis bulbi. I would say we have basically a liquid vitreous, and then there's kind of unusual cloudy vitreal membranes, and this interesting sort of multifocal to coalescing discoloration along the epichoroidal surface. And then both eyes have retinal detachment. So here's the retina in the right eye, and here's kind of a folded or somewhat detached retina in the left. So we have that, and we will take a look at the histology. Probably choose either eye and we'd be good. Let me pick, we're gonna go with the right eye. A good subgross end. So again, we have a relatively small, maybe slightly wrinkled eye. We have this interesting pink band along the epichoroidal surface. We have these pinkish intravitreal membranes. We have a segment of retina that kind of ends here, and we'll prove that that's tear looking a little bit closer. So we have detached and torn retina. We definitely have this really advanced cataract. Basically, we have some remnant lens fibers in terms of the nucleus, and it's just floating in a bag of liquefied lens protein with a very wrinkled lens capsule. So this would be characterized as a hypermature cataract. All right. So now the cornea is facing to our right or so. I just proved that for you to orient you. I promised we would confirm for you that this was a retinal detachment and tear, and so it is. We have a torn end of retina here. And if we start to look closer in this retina, though, there's quite a few cells. Most of them are macrophages, and most of them are macrophages laden with sort of melanin. And then there's also some lymphocytes and plasma cells. But as we look around, we might start to see something a little bit interesting in the macrophages, but rather than go through there. We're going to find the best spot and drop in on that instead. All right. Let me find the best spot. Here we go. There's more of those macrophages sort of in the epichoroidal membrane, lining the epichoroidal surface, lining the retinal surface, infiltrating the retina. But I'm going to drop in here with this sort of fibrin thing that has a bunch of bluish things in it, just sort of free floating in the vitreous, which is our much better spot to go in closer. And we see that there are some things here that do not belong to the patient, non-mammalian cells. Unfortunate, yes. That was a weird way of saying it. We have a large number of cells that are admixed with fibrin and erythrocytes, and they do turn out to be algal sporangia. And let me confirm that for you with a closer look. So some of them, interestingly, look kind of non-viable. They are reminiscent of the yeast we just looked at, in that they're sort of round to oval. They have maybe a sort of poorly staining, maybe refractile wall. Some of them have this sort of indistinct eosinophilic contents, which interestingly kind of look like they might be dead. But a lot of them have these really basophilic nuclei. And if we look around, many of them look like they probably are just releasing daughter spores. So we have all of these much, much tinier structures, maybe sometimes filling the inside of these sporangia. Some of them have this sort of morula look. They kind of remind me of like blackberries or raspberries. And then if we look around, we might be able to find the classic Mercedes-Benz look, or peace sign, which I'm not sure if we're going to be able to find terribly quickly. But as we look around too, this one's kind of dead and doing a Mercedes-Benz.
Yeah.
Maybe it has 3 compartments, deceased Mercedes-Benz. But regardless, these internal divisions here, these internal septations, are proof of endosporulation. So this is an organism that does endosporulation. Let's see. As we look around too, we see that many of these are empty cell walls, and that's part of the endosporulation. This organism reproduces by endosporulating, and then those walls eventually rupture and release the daughter endospores. Let me see. I think we might have better luck if I switch to left eye, actually. All right. So we have another hypermature cataract and posterior synechia in this left eye. This cataract is just totally a bag of liquid at this point. And if we look here, we have our detached and torn retina in the left eye as well, and all this stuff around the retina. We'll look closer. We can confirm that there are similar algal sporangia, similar organisms in the left. I think this one maybe had some better examples of endosporulation for us. Hopefully, should be. Let me see. There was one that at least had a single septation that I really liked in here somewhere. Here it is. There's this one. It's 2 compartments. And then there's this one that's kind of Mercedes-Benzian, sort of, almost. There aren't really great ones. A lot of these empty cell walls will kind of fold on themselves too, and they kind of look like crescent moons or like fingernail clippings. So empty ruptured cell walls. All right, we spent enough time looking over the algal sporangia. So these are indeed algae. We have relatively few algae species that are infectious to mammals. They are most likely Prototheca, so we call this protothecosis. Technically, we can't distinguish Prototheca from chlorella species histologically. We would need EM essentially to detect whether there are chloroplasts in these guys or not, because we can get chlorella that are like not as green, I guess, essentially. But most likely Prototheca, and long story short, infectious algae is what we're looking at. There is a short list of organisms that endosporulate, apart from this one. Coccidioides is the other, maybe more common one seen in the eye, but the size and shape of these organisms and, is not consistent with coccidioides. The other ones are generally either not really going to be in the species, not going to be in dogs, or much, much larger, things like that. So we can narrow down to Prototheca because of the size, shape, and that this is an endosporulating organism, long story short. Interestingly, usually these infections in the eye, especially if they're first recognized by the time we get an eye, usually are what we refer to as leukocytically pauperous. Meaning they tend to be mostly algal organisms, and then relatively few inflammatory cells from the patient. This patient actually has a good number of macrophages responding, apart from these weird globies that are mostly algae. So that's kind of interesting. We don't always see that. There's a good number of inflammatory cells responding in this case. But oftentimes we'll just see like an eye full of mostly just algae, tons and tons of algal sporangia. This can present initially as a gastrointestinal condition. We've had patients go many years with unusual off and on diarrhea, things like that, and have everything but the kitchen sink thrown at them in terms of diagnostics. And it's not uncommon to only get a diagnosis by the time it's gone systemic. There are treatments that have been tried. People try antifungals, and they can be effective. I think the idea is that they may target some sort of chitin in the wall of the algae that may kind of cross over. But it's a not great prognosis, unfortunately, with a diagnosis like this. The additional history that we will add now that we have the diagnosis revealed is that they did do another in-house cytology in some of the new skin lesions that had popped up, even though the initial cytologies were kind of inclusive maybe or didn't find Prototheca. And they did find Prototheca on the in-house cytology and have sent it out for pathologist evaluation as well, just to confirm. And we'll get those results later. And then I did ask for a little bit more follow-up too. This patient actually hails from Michigan, which is kind of an unusual location for algae, but we've had it from states kind of all over the United States or so, mostly from the southern states though. This patient was originally rescued from Louisiana, along with her mother and litter mates, but she was only 8 weeks of age at that point, and she's 7 now. She is, let me confirm. Yes, she is 7 now. So I would imagine she picked up the infection somewhere in Michigan, which is interesting.
Allison's comment in here, Dr. Bentley said, I don't think there are any reports of survival.
Oh, yeah.
From systemic fungal infections.
Yeah, it's difficult. I think there isn't really a like thoroughly effective treatment is the main issue. And it's really rare. We don't get many of these. The last time we got an eye like this was like November of 2024 or something like that. I looked it up. She is being treated with topical and systemic antifungals, and we're certainly sending good vibes their way. So very rare, unusual type of infection to see. We don't see this all that often, and we get a lot of rare things being a eye-focused sort of tertiary lab situation. All right.
Taylor says here that she has one that's 2 years post-treatment.
Yeah, we've had one recently. I think that was a little bit over, 1 year or so between eye enucleations and things like that. So maybe
There's hope there, I guess.
there's hope. Yeah. Some people have found some degree of effectiveness with antifungals, so I think they're doing as much as they can, for sure. So, all right. And there's like 2 minutes, so I don't think I can show the last one. I feel like maybe we should just be done with this here. So.
Thanks, everyone.
I can't. Yes, you're right. Stop sharing. Wait, where did the recording go?
I went to end the meeting.
There we go.